Imagine, just for a second, that every single time you laugh at a joke, or, every time you sneeze, you have to worry about a sudden leak,
Right.
or every time you try to lift a heavy box or go for a run, you're constantly mapping out where the nearest restrooms are. Maybe you're avoiding social events altogether. It sounds incredibly stressful, right?
It is profoundly stressful. And I mean, the reality is that up to 50% of women will experience stress, urinary incontinence, or SUI, at some point in their lives.
Wow, 50%.
Yes, half the female population. Yet, because of the stigma and the sheer embarrassment surrounding it, millions of women are suffering in absolute silence.
Yeah, that's just wild.
Yeah.
And traditionally, the medical fix for this was like an agonizing surgical mesh.
Which has its own massive set of issues.
Right. But today, these high-end clinics are charging thousands of pounds for a radically different approach. They're taking your own blood, spinning it in a centrifuge, and injecting it back into your pelvic floor.
Yep, often marketed as the O-shot, or vaginal platelet-rich plasma.
Exactly. So for this deep dive, we are cutting straight through the glossy brochures from places like London's Harley Street, and we're weighing them against dense, peer-reviewed medical literature.
See what the data actually says.
Right. We need to figure out if this so-called liquid gold can genuinely cure stress incontinence, or if it's just, an incredibly expensive trend taking advantage of a silent epidemic. So to kick us off, how is a needle supposed to fix this?
Well, to understand why an injection of your own blood might actually work, we have to look at the biomechanical failure happening with SUI. We're looking at a structural degradation of the pelvic floor muscles and the urethral sphincter complex.
Because of aging, mostly.
Aging, yes, but over time, the intense physical trauma of pregnancy and childbirth, coupled with the hormonal shifts of menopause, degrade the submucosal vascular plexus.
So the collagen breaks down.
Exactly. The tissues lose their elasticity and their blood supply. When you cough or laugh, the sudden downward pressure on your abdomen just overwhelms that weakened sphincter and urine escapes.
The valve is physically compromised.
Right. Structural support system fails.
And for decades, the gold standard for moderate to severe SUI has been to go in and artificially support that valve with surgery. Specifically, inserting a synthetic mesh to act as a permanent physical hammock under the urethra.
Yes, the synthetic midurethral sling. And while that can be highly effective at stopping leaks, the complication profile is significant.
Like, what kind of complications?
We are talking about severe risks, visceral injury, voiding dysfunction.
Meaning they can't pee at all.
Exactly. A patient suddenly can't empty their bladder, plus chronic pelvic pain and mesh erosion, where the synthetic material actually degrades and cuts through the delicate vaginal wall over time.
Oh, wow. Okay, hearing that, it makes complete sense why a woman would desperately seek out a non-surgical alternative, even if it sounds like science fiction.
It does sound a bit sci-fi.
Right. So the alternative we're looking at is vaginal platelet-rich plasma, or PRP. The process involves drawing a small amount of the patient's own blood from their arm, spinning it in a centrifuge to separate the platelets, and then injecting that concentrated plasma directly into the vaginal and periurethral tissues.
And the most vital concept here is autologous. Because the provider is using the patient's own biological material, there is virtually zero risk of an allergic reaction or a foreign body rejection.
You aren't implanting a synthetic mesh that your immune system might attack.
Exactly. You are relocating your body's own native cellular materials.
Is this essentially like a vampire facial but for the pelvic floor?
That's a great analogy, actually.
Are we just taking the body's emergency repair crew straight from the bloodstream and dropping them off at a new failing construction site?
That is the exact mechanism. You are relocating the first responders. Inside that centrifuge, the blood separates, and we isolate the platelets, which are basically biological reservoirs packed with healing proteins. The heavy spinning process concentrates these bioactive proteins and growth factors, specifically things like platelet-derived growth factor, or PDGF.
And TGF-beta and VEGF, I saw those in the sources.
Right. Transforming growth factor and vascular endothelial growth factor.
So instead of just viewing these as an alphabet soup of acronyms, are these growth factors more like foremen arriving at a construction site, pulling local fibroblasts out of retirement to start laying down fresh collagen bricks?
They absolutely operate like cellular site managers. When these highly concentrated factors are injected into the periurethral tissue, they trigger a massive biological cascade.
Oh, wow.
They stimulate those dormant fibroblasts to synthesize new, dense collagen. They also trigger angiogenesis, which is the creation of brand new, healthy blood vessels.
So in the context of a failing urethral sphincter, This cascade actively thickens and rejuvenates the tissue.
It restores the vascular plexus that was lost during menopause, yeah. You are improving the structural integrity and resistance of the sphincter complex from the inside out, completely without synthetic bulking agents.
Wait, I'm stuck on something here.
Sure.
I mean, I have PDGF and VEGF flowing through my veins right now. If my urethral sphincter is weakening, why isn't my body just healing it naturally? Why go through the trouble of drawing the blood and using a centrifuge at all?
It's a great question. It comes down to concentration and targeted location. Normal circulating blood only maintains a baseline level of platelets.
It's enough to clot a paper cut, basically.
Right, but it is nowhere near enough to reverse years of chronic tissue degradation in an area that already suffers from poor blood flow. The centrifuge process changes the math entirely.
How much more concentrated are we talking?
We are delivering 5 to 10 times the normal physiological concentration of these growth factors directly into a biologically dormant area.
Oh, okay.
By injecting this hyperconcentrated serum, you are creating a superphysiologic regenerative stimulus. You are effectively tricking the body into believing a major trauma has occurred in the pelvis, forcing it to send an overwhelming, localized healing response.
Biology sounds bulletproof on paper. You trick the body, the foramen lay the bricks, the urethra tightens, but bodies are messy.
Very messy.
When we take this out of a theoretical textbook and put it into an actual patient with a compromised sphincter, does the math hold up? I want to look at the objective data from the clinical trials because the results seem to vary wildly depending on the severity of the incontinence.
They do vary. The data paints a very specific picture. For example, a recent pilot study out of Dehradun tracked women over 6 months following PRP injections.
And what did they find?
The defining takeaway was that patients with mild stress incontinence showed a vastly superior biological response compared to those with moderate incontinence. The regenerative capacity seems to have a structural ceiling.
Which totally tracks with a 2024 trial by Sarah Luck and colleagues. They took 60 women and tested a combination approach.
Ah, yes, the combined trial.
They found that pairing PRP injections with standard pelvic floor muscle training Kegels essentially was far superior to just doing the muscle training alone. And they didn't just ask the women how they felt, they measured this objectively.
Right, using the 1-hour pad weight test.
Exactly. They literally weighed an absorbent pad, had the patient perform an hour of intense physical activity, and weighed it again to measure the exact gram weight of the leaked urine. The women who received the combined PRP and muscle training saw massive reductions in leaked weight.
The synergy in that Sarah trial is fascinating from a biomechanical perspective. Pelvic floor muscle training provides mechanical stress, which tells the tissue how to align the new collagen fibers that the PRP is aggressively generating.
So the PRP provides the biological building blocks, and the exercises provide the architectural blueprint.
Precisely. It's objective, measurable proof of efficacy for mild to moderate cases.
But then we hit the Chiang trial from 2022, which looked at women with severe SUI, specifically a condition called intrinsic sphincter deficiency, where the internal valve is profoundly compromised.
Yes, the Chiang trial results were quite telling.
They reported an overall success rate of about 50%. Initially, around 46% of the women achieved complete absolute dryness. But that number plummeted to 27% at the 12-month mark.
That's a significant drop-off.
Why the steep drop-off, though? Does the new collagen just dissolve, or is the biological stimulus wearing off?
Think about the half-life of biological regeneration. PRP kicks off a massive collagen-building phase, but it doesn't permanently halt the aging process or reverse ongoing hormonal deficits.
Right.
After 6 to 12 months, that initial burst of superphysiologic stimulation fades. The foramen leave the construction site, and natural tissue degradation resumes. In cases of severe intrinsic sphincter deficiency, the underlying anatomical defect is simply too large for a temporary boost in collagen to permanently overcome.
The new tissue eventually just yields to the chronic mechanical pressure.
Unfortunately, yes.
So here's where it gets really interesting to me. If a rigorous clinical trial shows complete dryness dropping to 27% after a year for severe cases, how are high-end clinics on Harley Street charging between $1,150 and £1,500 per session?
It's quite expensive.
And aggressively advertising 90% success rates with results lasting 18 months? Are the clinics just spinning the data as fast as they spin the blood?
Well, the discrepancy comes down to how success is defined in a laboratory versus a commercial clinic. In a strict clinical trial, like Chang or Sereluk, success is defined by absolute binary metrics. 0 grams of urine on a pad test. Complete total dryness.
So if a patient leaks even a few drops, they might be classified as a statistical failure in the trial.
Exactly. But in a real-world clinic, success is highly subjective. If a woman comes in leaking 10 times a day and after the PRP injection she only leaks twice a day, she hasn't achieved absolute clinical dryness.
But an 80% reduction in daily leaks completely changes her quality of life. She can go for a run again.
Right. She might happily report that treatment on a post-procedure survey as a resounding success, which the clinic then uses in their marketing.
And that subjective satisfaction is incredibly valid for the patient.
Absolutely valid. However, because the long-term data shows that regenerative drop-off, the broader medical literature still considers vaginal PRP an emerging or experimental procedure for SUI. We need much larger, standardized, multi-center trials to solidify the exact protocols and long-term booster requirements.
Before it becomes a standard, insurance-covered medical therapy.
Exactly.
Well, if patients are thrilled with an 80% reduction in leaks, that explains the clinic's success rates. But if you look at how these clinics are marketing this, they aren't just selling a dry cough. They're leaning incredibly hard into a highly marketable secondary gain.
They certainly are.
Which brings us to the actual trademarked name, the O shot, where the O stands for orgasm.
The conversation shifts heavily here from pure urogynecology into the realm of sexual wellness and cosmetic gynecology.
Because the exact same growth factors that repair the collagen and trigger new blood vessels to tighten the urethra also happen to do wonders for sexual function.
Biologically, it's identical. Better blood flow and healthier, newly vascularized tissue naturally lead to improved physical sensitivity.
It restores natural vaginal lubrication, significantly increases local nerve sensitivity, and heightens orgasmic intensity.
And there's rigorous data backing this up. A recent randomized controlled trial published in the Green Journal, which is the highly prestigious journal of obstetrics and gynecology, validated that vaginal PRP significantly improves patient-reported sexual function scores across multiple metrics.
There's massive drama attached to that Green Journal study, though.
Oh yes, quite a bit of drama.
Because the term O-shot isn't a medical classification. It is a registered legal trademark owned by a physician named Dr. Charles Runels. And after the Green Journal published their findings validating vaginal PRP, Dr. Runels publicly criticized the researchers.
Because they didn't follow his exact patented protocol.
Right. The researchers injected the anterior vaginal wall, but they deliberately skipped injecting the clitoris. Runels argued that if they had followed the complete O-shot protocol, their sexual function results would have been exponentially greater.
It highlights a really fierce tension in modern medicine between independent academic clinical research and proprietary commercialized medical protocols. The researchers were testing a general biological concept.
Well, the trademark holder was defending a highly specific, standardized procedure. So Dr. Runels is essentially saying they baked his cake but left out the sugar and then judged the recipe.
That's his argument, yes.
But wait, this raises a fascinating point. Why is a medical procedure trademarked like a fast food burger in the first place? Doctors don't trademark appendectomies or knee replacements.
They don't. But from the perspective of the trademark holder, it is a necessary mechanism for quality control in an entirely unregulated frontier.
Unregulated how?
Well, if any clinic can draw blood, throw it in a cheap, uncalibrated centrifuge at the wrong speed, inject it randomly into the vaginal wall, and market it as an O-shot, the patient might get terrible results. Or worse, an infection.
Oh, I see.
A trademark ensures that providers are legally required to undergo specific training. They must use FDA-approved centrifuges that are scientifically proven to actually yield the correct concentration of platelets.
And they must inject in the precise, anatomically correct locations. It's a way to enforce a rigid standard of care in a rapidly growing cosmetic field that is moving much faster than traditional regulatory bodies can keep up with.
Exactly. It stops a patient from getting generic, completely ineffective plasma from an untrained provider who just bought a spinning machine off the internet. It protects the integrity of the cellular protocol.
Though undeniably it also adds to the cost, the commercial exclusivity, and the marketing hype surrounding the treatment.
It definitely adds to the hype.
We have covered a massive amount of ground today, from the microscopic behavior of fibroblasts to the commercial battles over trademarked injections. Let's pull all these threads together for you, the listener. Stress urinary incontinence is incredibly common, and the biomechanics of it, the loss of collagen, the failing vascular plexus, are an unfortunate but natural part of aging in childbirth.
Yes, very common.
And platelet-rich plasma offers a fascinating biological, mesh-free alternative to traditional surgery. It works by heavily concentrating your body's own native healing factors to trick your pelvic floor tissue into regenerating itself.
And based on the current objective evidence, it appears highly effective for women dealing with mild to moderate SUI, especially when combined with targeted pelvic floor muscle training.
Plus, it carries the significant secondary benefit of enhancing sexual wellness.
It does. But the clinical literature shows that the biological stimulus is temporary, particularly for severe intrinsic sphincter deficiency. It is an out-of-pocket luxury expense, and you will likely need ongoing booster shots to maintain the structural integrity of the tissue.
But you don't have to jump straight to the operating table for synthetic mesh surgery. There is a whole new frontier of non-surgical regenerative options out there. It is absolutely worth exploring and discussing these biological alternatives with your doctor.
Absolutely. If you or someone you know are suffering in silence, mapping out bathrooms and abandoning physical activities, you are not out of options. The landscape of urogynecology is evolving rapidly.
And that brings me to a final, slightly provocative thought to leave you with today. Throughout this deep dive, we've looked at how regenerative medicine is literally turning our own bodies into the pharmacy, using our own blood to heal our own degraded tissue. But as these incredible autologous therapies advance, how is the traditional healthcare system going to adapt? Will massive insurance companies ever agree to cover treatments that rely on our own biology to prevent surgery?
It's $1 million question.
Or will these deeply life-changing therapies remain a luxury, only accessible to those who can afford to drop 1,000 pounds out of pocket for a chance to laugh without fear? Something to think about.